Just sort of things that I didn't think of in advance with this case was that it's already been shortened. If you're going to revise it, probably need to take notice of the fact that it's been shortened once already, and the same that you lengthen it, because it may often when you're shortening in this in a tree, you're leaving the sciatic nerve at its maximum tension. This isn't loose, and it's quite bone can osseointegrate onto cement, and there are post-mortem studies looking at interface between polymethylacrylate and bone, showing that it remodels around it. It doesn't necessarily have to have a fibrous interface between the cement and bone. And this is recovery room film. So there's a pelvis view. This is the in recovery. What have we done to the length? It's hard to tell, isn't it? I've just done, they're prophylactic cables. The cement was really quite difficult to get out. A couple of perforations and cracks. This is the Nesbron, and there's the vesitrochanter level of the teardrop. You can't see much else, but this is a tantalum cup with an augment. So she went round to recovery. A lot of pain when she woke up. Over the course of the next 12 hours, developed a foot drop. Normal, active dorsiflexion, then lost the foot drop. Lost dorsiflexion. What are we going to do? So you start by how are you going to tell that? What are you going to do? So there's no hematoma. Would you like that long? 6 hours? So it's 7 in the morning. you do water around 7 in the morning, just got a foot drop, which is developed between surgery finished at 5 in the evening. Okay. So I actually just booked an operating room and we went back as soon as I could, which was 3 or 4 hours later. How are you going to shorten it? I think you've got to do all the things you said. Rule out a hematoma and shorten the femur. Even if there's a hematoma, I'm going to shorten the femur. Do we do it on the femur or do we do it on the acetabulum? Yeah, how much can you shorten it by changing the head? I think I've lengthened it 2 centimetres. This is an Esron, so your fixation is here. In the process, managed to lose this. The people with dysplasia have brittle bone, and we operated on it. And this all fragmented when I shortened it, and I finished up actually taking the sleeve just fell out. So with the jam, at this point, I had no backup implants. I didn't have a distal sleeve, and got a really tight press fit here. Stable, and that will osseointegrate. In order to, this is sort of quite comminuted now. Smarter, yeah. No, I thought I could fix it. So during the sciatic nerve, in fact, how do we monitor it? How do we monitor the sciatic nerve after this? After we've got an injury and get immediate recovery the next day, what do we tell the patient and how are we going to monitor it? Will or won't?
But it may take up to 12 months, and that clinically to begin with, while they're still an inpatient.
Yep.
And then they still have no.
She had a foot drop, pretty profound foot drop, some weakness of ankle. Grade, well, 2 grades of decrease of plantar flexion, so it was incomplete. If she said to her, what's it likely to be in 12 months' time, so well, there might be a recovery, what's the most likely event? Do they get good?
Most likely.
Burns, it hurts. What's going to go away? Yeah. Well, in fact, that's the thing. It goes the way the slowest, if ever, is the dysesthesia and hypersensitivity. And I don't know whether you should tell them that early on, but that's certainly the reality. She actually has got quite good motor recovery and very poor. But well, it's more than 5 years. Very hypersensitive, several years, with using all the drugs. So, but a week later, she was left in quite her. That nurse left me alone in the bathroom, and I fell over. What are we going to do now?
I want to get echo the whole thing as well. I'm sure when you read the ability that I was produced and then created in theatre to see how very difficult situations in patients
Yeah.
And take some of the precautions that she's going to need to be abiding by with her ASO on and maybe even her adjustment went out for the next 6 weeks. Speaking to
Well, we're still friends and talking, but she's gone through a lot. We've gone through a lot together. So I did it. It was difficult to reduce closed, but I reduced it closed because the tissues are tight. It's like firing an arrow out of a bow, trying to get it back in. Felt very stable until she dislocated down. And what became clear then was that the trochanter was not united. The trochanter fragmented, became ununited, and migrated anteriorly and hinging with flexion.
I would get some more imaging. I want to know what kind of stuff I've got left with the trochanter.
I had a very clear recollection of what's there, not much.
Yeah.
You're looking, once that trochanter moves, you're looking at the lateral aspect of much of the bed that's there.
The metal road is impinging on the
trochanter's impinging, the actual trochanter. You know how I'm sorry I don't have an X-ray of it, but you know how the trochanter, the way it migrates, once it loosens, once you lose it with the grip, it goes anteriorly as well as superiorly, and it's with flexion that it will impinge on the extra-articular structures and just lever it out the back.
So the next step is that we're going to need to try and.
So what are the principles? What do you need to do now?
We need to get the trochanter back where it's all.
Try and remove that impingement. Yep.
So inferior and posterior. Get it to.
Try and get it to unite.
And we need adequate fixation.
Yeah. Anything we can do to the articulation to make it more stable?
We can remove the polyethylene for the constraint liner.